Hello, my name is Ginger Yarber, and I am the Chief Clinical Officer of IDD, TBI, and Olmsted for the Division of Mental Health, Developmental Disabilities, and Substance Use Services. The purpose of this presentation is to walk through the quarterly data summary for the Inclusion Connect's quarterly report for the reporting period of July through September 2025. This report is posted on the Inclusion Connect's website as of January 15th, 2026. Inclusion Connects is a North Carolina Department of Health and Human Services program that connects people with IDD to more choices and more access to services and supports. This program is a collaboration amongst North Carolina DHHS divisions, including the Division of Mental Health, Developmental Disabilities, Substance Use Services, Employment and Independence for People with Disabilities, and Medicaid. To provide resources for connecting people of all ages and abilities with IDD to services and supports available to live, work, and thrive in their chosen communities. To support people with IDD in their communities, Inclusion Connects focuses on improving access and enhancing the housing array for people with IDD, promoting access to services for people in need of services, including those on the Innovations Waiver waitlist, addressing the direct support professional or DSP workforce shortage, including connecting DSPs with providers and people with IDD, and supporting competitive integrated employment through Inclusion Works. As one of our main focuses is access to community living, we report on in-reach transition planning following in-reach and diversion from institutional settings. Institutional settings include intermediate care facilities or ICFs, state developmental centers like Murdoch, psychiatric residential treatment facilities or PRTFs, adult care homes, and other institutions. In-reach is the act of intentionally and purposefully educating people with disabilities in an institutional setting on benefits and services available in a community-based setting. This is done primarily in person and provides opportunities for meeting other people who live in the community. The purpose of In-reach is to provide information and education for the person and family to make the best decision for their individual family circumstances. In-reach processes are in development to standardize frequency and inform decision-making processes for all institutional settings. This quarter, we saw a sharp increase in face-to-face in-reach from the previous quarter. This means more care managers were meeting with people in institutions. It's important to note that there's no expectation for the number of people who receive in-reach to increase quarter over quarter due to the current lack of standardization across the plans. At this time, people receive in-reach typically annually. We expect people to receive in-reach regularly because people's needs and the system changes over time. For example, 5 years ago, there were no 1959 supports. So if you did not have the waiver, there were really very few other options for services. Now we have those services and want to make sure people know so that they know they have a choice. This slide is showing data related to the number of people who chose to participate in planning on moving after receiving in-reach. So of the 580 individuals who received in-reach, 108 individuals chose to start planning to move into a community setting. So that's about 18.6%. A community setting looks different for different people. This may mean living in a house with friends, living in a house with family, living on your own, or any other number of types of living situations. For those who didn't choose to move, it could be for a number of reasons as well. They may have lived in their current ICF for the last 20 years and they consider that home. They may need high medical supports, which they don't think can be duplicated in the family home. But the goal is ensuring that people understand what is possible, what's available to them now, and again, making the right decision for their current situation. This slide shows data on diversion and transitions. Diversion involves identifying people with IDD who may be at risk of moving into an institution and connecting them with the services they need to stay in their own home and neighborhoods. This may mean linking to 1959 services, mental health services, other possible waivers, and other state programs. You will see we saw an increase in those who were diverted in the reporting quarter. During this quarter, the tailored plans in the state were actively working on standardizing the definition of who is eligible for diversion. This likely resulted in more people being identified, and we expect to see this number increase once it's incorporated fully into the tailored plan contracts. This chart also includes the number of people who moved out of institutions. We expect to see this number fluctuate over time as slots come available and people indicate desire to move. As I said earlier, there are more services available now without a waiver slot than ever before. Those services include 1915I services, state-funded services, and other possibilities. The waiver is still available, but there's a tremendous wait list. We monitor that number along with the number of people who are on the wait list who are receiving IDD services while they wait. The Innovations Waiver is a program that allows for an array of IDD services to be provided in the home and in the community. For years, this was the primary source of services for people with IDD. It's considered the Cadillac of services or the golden ticket. Innovations relies on the allocation of slots from our General Assembly. So there are some years where we get some allotted, there are some years that we don't. For the most part, we rely on vacated slots to bring people into the waiver. People leave their slots for a number of reasons. There are some people that may move out of state. They may move into an ICF. They may pass away. And in some circumstances, they may feel like they no longer need the slot. As you can see, there is a wait list for services that we monitor closely. And as of 9/30/2025 or September 30th of 2025, there are 20,150 people on the wait list. As I said on the previous slide, slots are finite, and additional slots must be allocated by the General Assembly. Currently, there are 14,736 total waiver slots. As of September 30th, 2025, there were 14,185 active or slots being actively used. And when we say active, that means there's a person assigned to that slot. So there's somebody that actually, that slot has a name, and they are actively able to bill innovation services. You can see that there's a discrepancy between the total available waiver slots and the total active, and that's because there are 123 reserve slots. There are slots that are reserved each year for military transfers, emergency slots, transitions from, there is another waiver called Cap C for children, and as those children transition into adulthood, there is a possibility that they might need to transition into an innovations waiver. And then there are slots for a program called Money Follows the Person, or MFP. MFP is a program designed to support people who choose to move out of an institutional setting and into the community. There are also 428 inactive but assigned slots. So slots can be inactive, so nobody's billing against those slots, but assigned to a person for a number of reasons. For example, if someone recently gets an innovations waiver slot, it can take 90 days to enroll in the waiver, especially if the person is going through disability determination. Slots are also held if a person temporarily enters an institution. So for example, if someone needs hip surgery and has to go into a skilled nursing facility for rehab, their slot would be held. And finally, a slot may be held to the end of the waiver year if a person passes away. But again, there are services while you wait for an innovation slot. And for many people, the 1950I service options may meet their needs to live at home in their neighborhood. During this reporting quarter, we noted 7,524 people, or approximately 1/3 of the people on the wait list, were able to access an IDD service while they waited. And we want to see that number increase. There are more details on our innovations waitlist dashboard, including demographics, other services accessed, wait time, and looking at the number of people with Medicaid. One thing that we noticed, there are significantly more people with Medicaid than the number of people accessing services. And all of this data and those discrepancies are used in program design and service implementation. So while we're interested in the services people are accessing while on the waitlist, we also want to increase access to 1915I as a whole for the entire IDD community. 1915I is inclusive of community living and supports, respite services, supported employment, and community transitions. Tailored care management is not considered a 1915I service. During this quarter, we saw a slight decrease in the number of those who received 1915I services. It was less than 2%. One quarter does not necessarily indicate a trend, and it may be due to some seasonal fluctuations. A lot of people vacation during July and August, so there could be people out of town. And then school starting tends to impact schedules for those who are in school or for workers that are in school themselves. We continue to monitor this closely and anticipate this number to go back up over the next quarter. So just because someone has an active authorization or bills a single unit in a quarter, that does not indicate true access. We can authorize all sorts of hours, but if there's not a direct support professional to work those hours, then is it really access? So in order to monitor workforce health, we look at the number of community living and support hours authorized versus the number of community living and support services actually billed. We set a utilization target of 85%, so we want to see people using 85% of the hours they're authorized for. This number is set at 85% to allow for those vacations. People get sick, and sometimes, let's be honest, people just need a day off from services. As you can see for the quarter, VIA and partners exceeded the target of 85%. Alliance and Trillium were below the target. We are working with our tailored plan partners to understand what the possible barriers are to hitting the target, but also to learn from the successes in those tailored plan areas where the target is being reached. We want to encourage learning from each other to support people with IDD across the state. Thank you for listening to this presentation. We will continue to post the Inclusion Connects quarterly report summaries each quarter to keep our community up to date and with transparent reporting. Please feel free to send any questions to us at dmhiddcontact@dhhs.nc.gov.